there is only one way through anatomy. Anybody go through A&P 1? Okay. One of the best study tools, testify if I'm right here, is simply a blank diagram and then you label it. That's the way. So here's my recommendation. We don't do a ton of anatomy here, but there are a few things that we do anatomically or in regards to anatomy that are very, very important. One is the airway structure, one is the abdominal contents, and another is a drop of blood through the heart. Those are the three big ones, okay? What that means is my recommendation is that you go home, you take a piece of paper with a printed airway anatomy, trachea, carina, all the way down to alveoli. You either laminate that sucker or put it in a little plastic binding, and then every morning when you walk up, little coffee, text a vegetable to your whomever, and then you get on this sheet and you're labeling it in a dry erase marker. Then you reference it, make sure you got it right. Great. Next day, coffee, vegetable, erase, recreate. Like there's no, until you can do it from memory, there's no, in my opinion, there's no way through anatomy understanding except for repetition. Now, I'm going to bring up some things. We're going to try to spend more time physiologically than we do airway, because again, I just say, hey, here's some airway stuff, and then you go home and you memorize it. That's why essentially the homework due Thursday is just some instructions. It's like, hey, on a blank sheet of paper, draw the airway, and then also label some of the processes. That's what it is. Now, the larynx is the dividing line between the upper and lower airway. That is testable material for sure. The larynx is the dividable line. The question becomes, what do we the larynx at? Right?
The larynx is the dividable
dividing line.
Oh, the dividing.
So above larynx is upper, below larynx is lower. Did I say that right? Upper, lower? Okay. I have a suspicion that you can slice it even thinner, that it's the glottic opening, the vocal cords, but I don't know that. And so that means our lower airway contains things listed here: trachea, bronchioles, bronchi, carina, these kind of things, alveoli. Many of our conditions are going to be lower airway problems, because how would you fix an upper airway problem? Suction, clear it, right? Yeah, bypass the tongue, snoring obstruction, very, very good. You know, you can get some upper airway issues like larynx constriction, hypopharynx constriction, that might be from swelling tissue. That's going to be epi and the like. We talked about these views, right? Make sure you know I'm going to be referencing test questions that use these things: inferior, anterior, posterior, these kind of things, right? Superior, right? Remember the anatomical position, essentially, gloves out, mitts out, anterior being towards the front. Now, do I care about this? I don't, please forgive me, I don't know that I ask very specific questions about these. I don't think it's hard to remember, but I don't think I super care about these differentiating. Mostly, I need to talk about the larynx, and so it would behoove us to have a quick communication about what else is going on there. Rossi?
Why do you put hypopharynx instead of laryngeal?
They're synonymous terms. In fact, my A&P people, there's a couple of things, and right here is two of them, hypopharynx and, say it again? There's synonymous terms. Most of the medical field uses one, EMS uses the other. What do you call, does anybody know, they've got these folds in our nasal cavity. Do you know what those are called? Yeah, okay. Conchae, C-O-N-C-H-I-E-A or something, A-E or something like that. Okay, we call them turbinates, but they're synonymous terms. One group uses one group uses the other, so you'll probably see questions on the test more about turbinates than you would about nasal conchae, you know. Yeah, there you go. I think those are the only ones I can think of, and they occur right here. In any event, they're synonymous. Now, essentially, if we're just kind of looking at this, essentially, there's your nose, therefore behind that is the nasopharynx. Here's your mouth, behind that is the oral. Oral pharynx is often miscommunicated there instead of oro. OPA goes in here, NPA goes up there. The hypopharynx goes just below all of those other things, with the larynx being in front of it. The larynx exists in your trachea. Where's the majority of the hypopharynx? In your esophagus, right? So, I mean, essentially, air and food, gases and solids and liquids all share a space until a certain moment when they absolutely should not be sharing a space. This is a picture of a glottic opening, the vocal cords. with an epiglottis highlighted in white. A lot of times when you go in there with a laryngoscope, sometimes they have some UV lighting. It really makes that thing pop, and that's what we're looking at. Why would it be a problem if you took a bite of a Snickers that was meant to go down your grocery hole, but you couldn't defend your trachea, so it would go into your lungs? I'll say this, you say it back to me. Liquids collect solids. If you do an IV on somebody, well, you shouldn't, right? But if you do an IV, well, let's just say this. You get a cut hand, blood will come out of it, right? What is that liquid going to collect? Solids. Dirt. More important, I'm trying to say, anything that's liquid essentially is sticky and it will collect bacteria and infection stuff. We got to keep things that don't belong in your lungs out because in there is a liquid. And if a solid has access to it, it's going to stick around. It's called aspiration. That's an important word, aspiration. Not your aspirations, like what you want to be when you grow up. What I'm saying is when you get something other than a gas in your lungs, it's called aspirating it. It can be a liquid, it can be a solid. And when it gets in there, that liquid is going to collect solids. What I mean is if you get stuff in your lungs that don't belong there, you're going to get an infection inside. Now, to prevent that, to prevent things from going through your glottic opening, we need a little trash can lid to prevent the trash you're eating from going into your airway. That's the epiglottis. Epi meaning above. Well, I don't know that it means above. On top of, outside of, something like that. The glottis, we would know it as lay people as vocal cords, but it's referred to as the glottic opening. So your glottis are your vocal cords. Know this, it is the narrowest portion of the adult airway. Somebody say that back to me in a way that's not all stupid or sciencey.
The epiglottis is the smallest part of the throat.
Okay, I like that. Essentially, she means to say the glottic opening is the smallest part of your airway, right? Why is that relevant? I do want to keep it open. Well, in most people.
Probably going to be an issue.
Probably going to be an issue because it'll trap stuff. All right. We've got right here some cartilage. Your airway, essentially, is mostly a bunch of U-shaped cartilage, right? Kind of like armor on the front of your trachea to prevent damage. One of those is this big one, commonly called the Adam's apple, this thyroid cartilage here, this big one. You can feel it on me pretty easily because of all the testosterone that I have, probably. In any event, this big armor piece is shielding your larynx, your glottic opening. Okay? What I mean to say is if the person is choking on something, where do you, for an adult, where do you suspect that's going to be? Probably at the narrowest portion, right? Sometimes I can see it as a medic, sometimes I can't. When do we pull stuff out of people's mouths? When you can see it. What you can see here is, what do we say in here? GIF? GIF? GIF, GIF? I say GIF. Gift? Giphy? Anyway. In any event, this is a tongue. You can see, the reason I show this, because if I show you my tongue, you're like, oh, it's just this thin muscle or whatever. I'm like, no, if I could show you my entire tongue, you would see it's this absurdly giant thing. And one of the primary purposes of it is essentially to guide food down and open my epiglottis so that, close my epiglottis so that the food goes down the right place. Yeah. Because if it doesn't, then it might go in the airway. Guess who doesn't have control over this, right? Now, I should mention here, unconscious doesn't mean unresponsive. This one is a very difficult concept for people to get. Or it's not that it's difficult to understand, you just forget. Unresponsive does not equal unconscious. Do they often go hand in hand? Oh yeah. But here's what happens all the time. A person will come up and be like, whoa, hey sir, can you hear me? No response. Oh, okay, I must need to intervene on their airway in this. I'm like, no. They might still have a gag reflex. If a person isn't responsive to pain, they very likely don't have a gag reflex. So if I walk up and do a sternum rub on a person and they don't react, I'm 100% putting an OPA in them. If by some strange reason they start horking on it, right? I put it in, they're like, oh, I'm like, okay, well then that's the only way I know how to check. So I take it out. True work, true in love. So our nasal conchae turbinates. A lot of your body operates under these principles of surface area. There's a million different examples for us to be like, anyways, you know this teeny tiny part of your body? Turns out it's the size of the planet. It's the size of 10 football fields or whatever, right? Because a lot of our body works in these tiny little frames as needing to move enormous amounts of material, air, blood, whatever the case is. And so we need highly efficient devices. The turbinates, as we'll kind of call them moving forward, work a little like that. Instead of just having this hole in my nose where anything that brushes across the surface allows me to filter things out, I have a bunch of folds in there. Well, I do, you probably do too. A bunch of folds in there, and folds allow the increased surface area. So now that air is blowing in between those folds and collecting and filtering more and more and more. They call it conchae, like a conch for a shell, because it's spiraled, I guess.
So people who snort stuff, like hard drugs, is that disruptive?
Yes, it's profoundly disruptive. Yeah, it's, part of the reason people who like snort coke often have that little or whatever, because they have deterioration of the turbinates and stuff, and they're unable to filter like they should, and just the chronic irritation will do it for sure. Coke goes down as I've done some goofy things in my life for sure, but there's a handful of things I don't think people should do in a big way. Coke is one of them. My wife asked me once, she was like, hey, had you ever thought about doing coke? And I was like, yeah. And she's like, I don't think it's something that we should ever do, ever, And she said, well, I had heard that it was, that people felt really good on it. I'm like, no, it is the best day of your life. It is everything you think it is.
The weight.
Huh?
The weight.
The weight.
Just awake.
You are just awake. That is true. It's a stimulant. Say it again. It's funny. I could tell I must have grown up in a different place, because the first year I started teaching this, I was like, send them all home. They come back, they took up all the tests. I'm like, these were gimmies. And they're like, I don't know what heroin is or does. I'm like, oh, well, you got some homework to do, I suppose. Yeah. But a stimulant, something like cocaine, Molly, caffeine, these are all things that make you go up, make you go faster, right? They enact your sympathetic nervous system, up, up, up. Now, look. People more often die from opiates than they do stimulants, because just like the triangle, doing the work of breathing may not be great, or doing these increased numbers may not be great, but it's certainly better than going down, So cocaine essentially, look, here's a quick mention about my opinion of most drugs. Everything is in a sense a Faustian bargain, right? Today you've got some fun. Tomorrow you've got some more fun. The day after that, some more fun. Now, alcohol kind of takes tomorrow morning's fun and then puts it into tonight. That's what alcohol is. And the more you do that, the more it takes from tomorrow to make tonight more fun. There's obviously a diminishing returns in there, okay? Things like, mushrooms and LSD and stuff, they take all of tomorrow's fun and put it into today, which means today's awesome and tomorrow is not. Things like Molly will take, on average, 4 or 5 days and put it in, which means tonight is the best, literally. And then some people kill themselves in the next couple of days because they're all out of fun juice, So cocaine squeezes a lot of your body. It squeezes, let's say, your adrenal glands, which release epi and make your heart rate go up, make all of your vasos constrict. And it also squeezes your little fun bags, juice, let's say, in your brain. We'll talk about those later. But in any event, it squeezes these glands and makes all the fun come out, right? Okay, the reason why I say cocaine is one of them, you shouldn't do consistently, is because even though caffeine will chronically make your heart rate go up, which is not great. It shouldn't be running away without you all the time. Cocaine, yes, will do that. But here's the big hook. Cocaine causes atherosclerosis. Yes. That's why, essentially, I'm like, look, I'm glad you asked. So essentially, you've got a heart, right? And that heart has in it some arteries, okay? And the purpose of those arteries is to bring blood to your heart. No artery, no heart, Okay. Atherosclerosis is like having having an artery that has damage done. And so essentially plaque is building up on it. If this is what your artery is supposed to be and enough blood to come through to fuel your heart, atherosclerosis means now you've only got this much space. It diminishes the interior. So we can prove essentially that cocaine leads to atherosclerosis and all the other conditions that lead to high heart rate and high blood pressure. If there's one thing that's killing Americans that isn't sugar, it's high blood pressure. It affects your entire body, all your organs and everything. So if you asked, why not cocaine? I heard it was a lot of fun. I'm like, it's more fun than you could possibly imagine. That's not the issue. The problem is, and they're like, well, so you got a really gnarly come down? I said, it's not the come down. Lots of drugs have come downs. The problem is it destroys your carotid and arteries and gives you high blood pressure. That's why you should be very careful, in my opinion, never do it, So cocaine's way up there in my opinion. It's just like, but then so is smoking weed, for example. No, I always think there are a lot of things like heroin that's a stop button, whereas weed's more of a pause. I don't think it's that big of a deal, but smoking it is different. Smoking, in my brain, I can't get away from a conversation about cilia and alveolar cells. I'm like, dude, you can put that stuff in a brownie, you can put it in a slushie, you can put it in a million ways that don't involve destroying your lung tissue. They're legal in Michigan, so every second person I know there is high every single day on gummies. Yeah. I mean, I recommend you abide the law when the law is worth abiding, that's for sure. But more than anything, I mean to say, look, here's a conversation. My kids ask me, right? Hey, what do you think about drugs? I say, well, which drugs? Sugar's a drug, oxygen is a drug, and they're like, well, you know what I mean, street drugs. I say, okay, well, even that varies, right? You take heroin, you take ketamine. I have friends that did it once and never came back. I don't mean died, I mean never came back. I mean, they did ketamine, it snipped some wire, and they were never the same again. Now, I know a bunch of buddies that did ketamine or whatever, and they're fine. But there's a couple of them where I've seen people never come back ever after once. It changes your brain chemistry. Weed does not do that. Oh, so weed's okay? I don't think so, dude. You ever been like trying to gear up for a marathon, popping a gummy every day? No, it's hard, it's difficult, right? I mean, some people live on it for sure. So I tell my boys, I say, look, if you're trying to be productive, weed's not helping with that. But then neither is alcohol, and I do that every day, so I don't mean to be. Anyway, again, I think these things to greater and lesser degrees, yeah.
I will say hypopharynx was interchangeable with laryngopharynx.
Yeah.
We see laryngopharynx or hypopharynx.
Hypo. But I don't know that you'll see either one of them. Mostly, when I say larynx, I want this stuff as reference points. I don't think I have test questions that are like, point to the hypopharynx. Like, no, I care a lot about the larynx though. Most of your conversations will be had at the larynx and below. Aspiration pneumonia, when you get stuff in your lungs that don't belong in there, you get something other than the gas, liquid, solids, whatever. That'll cause infection. We talked about this in part, so I'll skip by. No, I don't have butter here because of surfactant, you nitwit computer. I have butter here because essentially if you bypass the nares and the filtration, then you get all of this goop in your lungs. I got a picture for you here. Just kidding, I don't. But it's super gross. This is an NPA. I just superimposed the picture, but the idea is it goes into your nose, through your nasopharynx, down to your oropharynx, and literally bypasses the back of your tongue. And you can do this on conscious people. No contraindications for a nasopharynx except basilar skull fractures and facial fractures. Be mindful of that. There are people we can't do an NPA on. The thought is if I think you have a skull fracture and I push this to bypass your tongue, but it goes through your skull and into your brain, that'll kill you. Now, that might be the right answer. If I think facial issues and skull fractures, I don't do an NPA. That might be the right answer. My recommendation is you call med control, because there's not a lot of evidence to support that we're killing people by pushing NPAs into their brains. There's a ton of evidence about people being hypoxic and dying. So my recommendation essentially is if you go to, Emily goes to do an NPA and then Noah's like, hey, look, he's got raccoon eyes. I think this is a skull fracture. We shouldn't do that. And then Emily's response should be, oh, okay, then just ventilate him. I'm going to call med control for authorization of an NPA. Now that doctor might say, no, I read a book, no way. But they'll probably be like, yeah, if he's snoring, that's not good. I don't think you're gonna punch it into his brain. But just know that's the right answer. Similarly, an OPA goes into the tongue, past the tongue, but both cases, they are bypassing the tongue to keep it away from falling back there into the oral and hypopharynx. Number one obstruction, tongue. Good. There is a few bones that we're gonna bring up. I think I only care that you know about like 9 bones in the body. One being a sternum, another being the major long bones like humerus and things like that, femur, radius, ulna, tib, fib, skull. That's about it. Asterisks. Also these 3. First, let's talk about the thyroid cartilage. Essentially, it's this big shield, it's the big one, the Adam's apple, protecting your larynx. Got it? Above that, we have the hyoid bone. I don't remember its purpose. What's special about the hyoid bone? Yeah, I know. She's smarter, faster. Yeah, she's got a lot on you. In any event, the hyoid bone is the only free floating bone in the body. It doesn't attach to anything. It's just sitting in your tissue there. Why do I care that you know that? Because I saw it on the registry once. Why do they care that you know that? No freaking clue. But there you go. Hyoid bone, only free floating bone. Get your free points. In any event, thyroid cartilage is largely this big shield of armor protecting this. Cricoid cartilage is unique because it's the only ring we have. Most of it is U-shaped stuff. The cricoid cartilage is a ring. One of the benefits of if you might say, well, wouldn't it be a good idea to just have rings all the way down? Not necessarily, because when food moves down your esophagus, it needs to stretch and expand. And if it had a bunch of cartilage in the way, it wouldn't be able to do that as well. Hyoid bone, thyroid cartilage, cricoid cartilage. What's the narrowest portion of the adult airway? The glottic opening, right? The cricoid cartilage, the cricoid ring, is the narrowest portion of the pediatric airway. Which means what? Why do I care? Oh, that was perfect. Say it again. Yeah, if a kid is choking, it's far more likely to be farther in there, which makes it harder to get out. Well said. This here is a summary of the stuff I this is the summary of the stuff I expect you to know, or at least have reference to, okay? This is that summary list. Now, there's a couple of things on there, like esophagus. Obviously, that's not the upper airway. It's just close to it. But moving forward beyond this point, I start to say, hey, if I reference things like, hey, point to your nasopharynx, point to your glottic opening, these kind of things, that you have a decent understanding of that. We're not going to spend a ton of time on it, but it's something you need to do in the future. Often people are confusing the maxilla and the mandible. Essentially, the reason I bring this up is to talk about the palates. Let's see, I hope I have a question on that. Do I want to spend time there? I don't think I do. Here's a representation of a pediatric airway. If I've got my glottic opening somewhere around here, right, you can see how as a child is in development, if that cricoid ring is a complete ring, then it is at the behest of growth. What do I mean to say? If you're small, so too will your cricoid ring be small. And as you grow, it will expand. The rest of this tissue can expand faster because it's soft tissue, it's not the cricoid ring. Now, this isn't 100% true, but as a reference point, most people's trachea are the size of their pinky, the internal diameter. Which means if you got tiny pinkies, you got tiny tracheas, yeah? There's some significant things you need to know about the differences between a pediatric airway. Number one, they got big, dumb baby heads, right? Everybody hands up around their head like this, so everybody can see your pit stains like me. There you go. Very good. Proportionally, if you were a baby, it would fill this space. Proportionally, this is how big babies' heads are in reference to their body. Now, they have a much larger tongue proportionally. It means it takes up much more of their space. They're harder to intubate. It's more difficult to get it out of the way. They're more likely to have snoring obstructions. Also, their larynx is more anterior. What does that fancy phrase mean? Forward. which is great because it may make them less likely to choke on stuff just directionally, but buddy, is it hard to get stuff out of them if it's in there. In fact, I dropped off a kid to I don't remember the question I had for the doctor, but it had been a doctor there. She had been a doctor there for years. And I said, hey, I'm intubating this kid. And I don't remember what the question was. And I asked her, what would you do, blah, blah. She said, honestly, I'm gonna have to refer you to someone else. I said, oh, that's okay. If you don't know, you don't know. I really respect you for saying that. She's like, yeah, I mean, how often do you actually intubate a kid, you know? And I was like, dozens of times. And she was like, I've been a doctor for 10 years. I haven't intubated some kids dozens of times. And I'm like, oh, we have different jobs. It was just interesting. I'm like, I remember when my wife was going under for anesthesia, and I was like, I know you're gonna say no to this, but can I intubate her? I've done it a million. I know I'll intubate my wife just fine. I'm not sure who you are, you know? Anyways, the children are often nose breathers, right? They're just breathing through their nose. It might change the way their oxygen is taken in. Might change the way that their ventilations are done. What's interesting to note is that kids are burning, they run hot. They're growing fast. They are eating up their resources nonstop, right? Anybody got teens yet? I don't think teens yet, right? Oh, my oldest is 13, dude's a garbage disposal. We go out to a Mexican restaurant, I drop a 20, he eats like a Mexican king for about 30 minutes. We drive 5 minutes home before we get in the door. Dad, I'm hungry. Ugh. Anyways, they are burning it up, and they got tiny lungs, they need, let's say, twice as much air. I don't know what the number is, but the point is that they need a lot, and so when they aren't getting what they need, they crash fast. They have very little reserves. Which means if you see an adult and you're like, ooh, you look sick, I want action. If you see a kid and you think, oh, you look sick, we are way down the line. They can compensate for they decompensate much faster. They don't have big lungs, big livers. We'll need to make sure that you can trace air, how it gets into our body. Right now there's air in the atmosphere. How do I get it into my body? Where do I start? Yeah, nose and mouth, right? Easy. You're an eighth of the way there. You'll need to be able to say essentially that it goes down in the trachea, as the English would say. From the trachea, it's going to go down into this bifurcation. Bifurcation meaning your single lane road now becomes 2 lanes. What's the name of that area? Yeah, that's right. Carina. The carina. It bifurcates into 2 bronchi. It's the plural form of bronchus. Left bronchus, right bronchus. They become bronchi. Which means if I have a bronchiole, if I have 2 of them, I have bronchioli. I don't know. I made that up. Specifically, I know that it works when I have an alveolus. 1 little alveolus. With 2 of them, I now have alveoli, right? The I is the plural form. Now, know this. The right brainstem, the right bronchus is often referred to as the right main bronchus, specifically to emphasize that it is shorter and wider. In most humans, it's shorter and wider. The point is that as we learn about how to go down into the airway there, if you get a peanut down there, which way do you think it goes? To the right. It's also important for me that you as EMTs know that when medics will go in there to intubate, sometimes they'll push it too far. And it'll go way down here. If a guy intubates too far, he pushes it too hard, does it go right or left?
Usually to the right.
My man, right? Good job. Oh, you need my key?
Yeah.
Down and to the right is a million printed things. Would you mind bringing them to me?
Yeah.
Okay.
Is
Good
the
to
same key in there too?
Yeah, but it's open.
Okay, sick.
Lit.
Print it off right now?
Or somewhere nearby. It's a stack of lab stuff. Thank you. Oh, I got some test question in here that's like, blah, blah, dude swallowed a penny, it went past the larynx, where do you think it ended up? And the answer is? Right. Very good. Here's what I want from you. Essentially, if you're working with a medic, he's intubated somebody, meaning pushed a tube all the way down here, and it should have ended here, but didn't. A sign of that might be poor chest rise and fall. Poor chest rise and fall. How do you suppose that medic needs to fix that tube? Back it up a little bit. That's it. So sometimes you could be looking at it, your medic's going to be all hot to trot and be like, pulse ox is low, end tidal's goofy, I don't know what to do, chest rise and fall. I'd be like, all right, princess, let me just go about 1/2 inch. There you go. There you go. I remember EMT said to me once, he said, I heard the dumbest thing in the world today. He's a brand new baby medic. I said, what's that? He said, I heard the paramedics save patients, EMTs save paramedics. And I was like, oh, yeah, yeah. And he's like, isn't that dumb? And I'm like, oh, no, you haven't been a medic very long. If you haven't had an EMT save your entire career for you, you have not been a medic for long, 100%. Now, we've got one trachea, 2 primary bronchi, and then tens of thousands of terminal bronchi. I got to read this. I don't remember this stuff, and you don't need to know it either. You need to know they exist, not how many there are. But the point is don't be misled when I show a single picture. Who's he talking to? Oh, come here. Look at his face, Emily. I wonder if, oh, you missed it. I bet we could tell the gender of the person he was talking to based on how, oh, I knew it. Yeah. Yeah. I saw it. All right. I'll show you pictures like this. Boom, alveoli, right? Just remember, there are millions of them. Millions of these alveoli. Something like stretched over a tennis court is how many? I don't know what the thing is. It's a lot. It's a lot. You have millions and millions of them. Okay, give me little deer antlers like this. Okay, now turn it down. Okay, this is what your lungs kind of look like, right? It's like the bottom of a tree or a tree upside down or whatever. Now, if I said, hey, point to your trachea, very good. If I said, hey, point to your carina, maybe down here somewhere, right? If I said, use 2 fingers, let's point to both of our bronchi. Okay, very good, right? Now, if I said, hey, take 1 finger, point to an alveoli. Yeah, my point is don't get to thinking that the alveoli, because they're at the end of the airway, means they're low in your chest. Yes, they are low in your chest, but the ends of the airway are everywhere. You have alveoli up here, 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 all over your lungs, okay? Now, don't get me wrong, there's more blood down here and more air up here, and somewhere in the middle is the perfect blend of blood to air ratio, but you've got alveoli all over, right? Ignore my gang signs. In addition to that, you've got a chest cavity. Inside of that cavity are 2 pleural sacs. Inside of those pleural sacs is a lung. So we've got kind of a lungception thing going here. We have a thoracic cavity. Then yes, we have 2 lungs, but those lungs themselves are in their own little sacs, their own little bags. Those are called pleural spaces. Inside of those pleural spaces is a liquid to allow them to be lubricated. If you have a car engine without oil in it, the metal on metal will wear thin fast and your car will break down. If you didn't have lubricating liquid in your pleural tissue, your lungs would struggle and break down. Pleural fluid is not surfactant. Pleural fluid is not surfactant. Yep. That's none of your business, and I'll thank you not to ask. We'll talk soon about how your alveoli require surfactant. Dish soap is a surfactant. It makes things slippery, right? We like that in our dishes so that the food stuff slips off, right? We like surfactant in our alveoli, to answer your question, because it keeps them open. It reduces surface tension. Is surfactant in your pleural space? No. Be careful with this. If essentially a person was bleeding into their pleural space, that would be a major problem. If a person had liquid in their pleural space, the question might be, well, is it physiological liquid or is it pathological? Is it a problem or is it natural, right? Surfactant is specifically in the alveoli to keep them from collapsing. Okay. A lot of times people just kind of think generically about fluid in lungs and they get those mixed up. If you got to use the bathroom, go ahead. We're running low, so I'm just going to keep going. In any event, how I remember, you'll need to know this: visceral versus parietal layers of the pleural cavity. Visceral versus parietal. Now, I remember this because evisceration is an injury where somebody gets cut across the abdomen and their organs come out. That's called an evisceration. Visceral refers to the organ itself. Which one of these layers do you think is on the lung organ itself, the visceral or the parietal? Visceral, because that's the part that means the organ itself, whereas the parietal is the lining of the chest wall. The reason we have to make sure that you know the distinction about pleural lining is because we need to one day talk about what happens when fluid and blood gets in there and causes pneumo and hemothoraxes. For now, you need to know that we have a thoracic cavity. Inside of that are two pleural spaces. Inside of each of those is a lung. So getting air in and out of your lung, not a problem. Air in and out of your pleural space, huge problem. Okay? Okay, pumpkin? In the center of your chest cavity, we have another area. This area is referred to as the mediastinum. If I said, hey, point to your mediastinum, I'd be okay with you essentially pointing to the center of your chest. Your heart and some of your great vessels are nestled right there in the center of your chest, in between your lungs. These are the things that are included in your mediastinum, in this area right in the center. I have a test question on there that says something like, which of the following is or isn't in your mediastinum? And you just got to look at the list and figure out which one does or doesn't belong. I don't remember how it's phrased. We need to teach you about what a mediastinum is because later we'll teach you about what it means when a mediastinum shifts. What's a phrenic nerve? What's it do? It controls the diaphragm. Where is it innervated through in your spine? Which cervical spine? C3 through C5 keeps the diaphragm and the phrenic nerve alive, yeah? Very good. Do you see here how it's tracing out of your spinal cord? Cheers. And it's going down to your diaphragm. If I snip those wires, your diaphragm fails. If I snip that spinal cord somewhere between C3 and C5, your diaphragm fails. If I damage that area and you get swelling there, your diaphragm starts to struggle, okay? But this is kind of what it looks like. These nerves go through. We're talking about cyanosis and spinal injury stuff. Well, let's not get into that. We'll talk about it later. Here's a list of lower airway stuff I expect you to know. We would expect to have anatomy stuff on the quiz. Right? It would say something like, what does the letter A, what structure is the letter A pointing to? Bronchus, bronchioles, alveoli, trachea, these kind of things, okay? This becomes particularly important because we need to be able to determine what wheezing is and how to affect it. Now, your alveoli are these little grape sacs at the ends of your airway, not at the bottom, the ends of your airway, right? In the alveoli, and why they're so important, is because this is where air leaves your airway and goes into your blood, at the alveoli. But you know this already, kind of, or at least you know that air isn't going from your mouth into your blood, right? It's going from your mouth into your trachea. And also, it's not going from your trachea to your blood, it's going from your trachea to your carina. You see the message I'm kind of getting here? Air may be moved through a lot of the airway, but doesn't cross over the walls, the alveolar walls, until we get down to the alveoli. If surfactant is emitted in these, it's essentially, I wonder if I have a little, not really. Essentially, surfactant is just a slippery thing in there. Slippery liquid. If I didn't have that liquid in there, all of your alveoli would collapse. And for air to go through the walls of the alveoli into the pulmonary vasculature, it needs to be open. This is why I said, I'm like, look, we can have a conversation about THC, but smoking it's rough because smoking anything damages the cells that make surfactant. And if you don't have surfactant production, you experience alveolar collapse. Maybe not so bad that it kills you, but you definitely experience collapse. It decreases surface tension if you don't have it, which decreases surface area of the alveoli, which means your body has to work harder to get oxygen in and out. Atelectasis is the term that means alveolar collapse. atelectasis. I don't need you to be able to pronounce it. I just need you to be able to point to it on a test. Now, if I reach in there and I squeeze your lungs so hard that I compress your alveoli, sure, we'd call that atelectasis. I'm compressing the alveoli. But generally, we are describing it in a medical sense, that usually it's a lack of surfactant causing collapse. But also, a person who isn't breathing, somebody that's not moving air, all of their airway is going to relax and collapse. Air is what keeps them inflated. Without air, it won't be inflated, it'll collapse. So essentially, not only would we expect people with a lack of surfactant, but also people not breathing. I also want to highlight that as air reaches the ends of our airways in the alveoli, this is where it's now going into the bloodstream. Each one of our alveoli has capillaries wrapped around it. I've got arteries that go away from the heart, veins that vacuum blood to the heart, and where they connect are capillaries. Show me the capillaries on your hand. You're probably touching your fingertip. But when I say capillaries on your hand, you could point anywhere. We check here for cap refill, sure, but you have capillaries everywhere. Why? Because capillaries are where essentially this gas is able to escape the vasculature and go into the tissues. Generally speaking, as an artery goes away from my heart, it's not depositing blood anywhere until it meets a capillary, and then it will go into the tissues. So what we're seeing here is, yes, some venules and arterioles, but the significance that's not well represented is that the capillaries of these on these alveoli is where gas is going from the alveoli into the blood, or from the blood into the alveoli. How we doing? You with me? Hemoglobin is what carries it. So here's my we're not going to do anything histological in here really, but this is what a zoomed in version of an alveoli looks like. See all the holes? The point is this is a real thin, teeny tiny thing where gas can exchange pretty freely. Do you want air to escape your lungs? Yes, you do. Why do I want air to escape my lungs? Because I need it to go into my blood and then into my brain. And it does so at the alveoli, right? See this little layer of surfactant I've got here keeping this open? We'll learn at a later date how CO2, well, we'll talk about it a little bit today. All right. Why we take a breath isn't to pull in oxygen. Now, we need oxygen to live, that much is true. But when your body says, hey, I need a breath, it's not because of oxygen. It's actually because of CO2. Now, we can prove that to you. We'll do this pretty quickly. We're all just going to hold our breath for as long as we can, okay? 1, 2, 3. It's not a shape. Okay. Your first impulse is to breathe out. Here you've been sitting without breathing for what was probably 9 or 10 minutes. And your first impulse is to breathe out. Your body exists on what's called a hypercapnic drive. It's a fancy way of saying your body is measuring the CO2 levels first, and the oxygen as a backup mechanism. What I'm saying is that your body is, if you put gas into your car and you push the pedal, combustion is going to happen and exhaust is coming out the back end, right? Well, your cells are kind of doing that too. Oxygen, sugar, and then combustion for energy. The whole purpose of the respiratory system, well, the primary purpose is to remove waste, carbon dioxide, and we're getting that waste because of oxygen plus sugar. That's cellular metabolism. A hypoxic drive is pathological. What does that statement mean? It's disease. It's abnormal process. Now, in your heart, we've got these little sensors. They're called chemoreceptors. I couldn't get chemoreceiver out of my head. That's why you see this guy. Basically, I love this. I don't remember where I read this. Your brain tastes your blood to know when to breathe. That's what a chemoreceptor is. We have stretch receptors. This is why pregnant women got to pee all the time. Not because they're making a lot of pee, which is often true, but because your bladder operates on stretch receptors. If I went in there and just poked it, the stretch receptor would be enacted and your brain would say, oh, I have to pee, which is why when you got a baby laying on your bladder all the time, it's constantly signaling, hey, I'm being stretched. That means pee. We have baroreceptors, which is pressure, and we have chemoreceptors, chemical receptors. Again, imagine, if you will, and I think it's important, just a bunch of little tongues hanging off your carotid arteries. That's some normal science for you. Basically, just taste testing the pH of your blood. And when they notice that it's too acidic because of the carbonic acid, because of the CO2, it will signal your brain to breathe. Now, there are some patients who have chronically high levels of CO2. These are our lung patients, people who have chronic obstructive pulmonary disease, people who have COPD. Every second patient you get in the field is going to have COPD. Emphysema and bronchitis are forms of COPD. What this means is some people's lung physiology is so bad that their CO2 levels are chronically high. They can't get enough CO2 out. They live in a state of hypercapnia. What happens there is it's like an alarm system. Like imagine the fire alarm went off right now. Maybe we'd all go out into the parking lot. After an hour, we came back in, it went off again. We might go slower to the parking lot. And after about the fourth time, we're like, okay, I'm pretty convinced that this thing is just ringing all day and means nothing. That's what's happening when people have chronically high CO2. The bell is ringing constantly, the body will then ignore it, and it will start enacting its hypoxic drive, where it starts saying, look, because my lung tissue is damaged, I always have high CO2, now I'm gonna start measuring O2. Why is that a problem for medical professionals? SpO2 is close.
It gives a false reading.
Gives a false reader, maybe. Today, your person has difficulty breathing. Could it be because they're low oxygen? It could be. If your body is constantly monitoring oxygen levels, might it do when I put you on high flow O2? It'll say, I got enough oxygen, guess I can stop breathing. Now, okay, I regret almost every time I say this. I think this is like interesting, so it sticks. This isn't for us in the field. Usually people that are getting hypoxic drive injuries, they're in the ICU for a week or whatever, they're on high flow O2. This doesn't happen in your ambulance trip. So don't be like, be careful with that, they have COPD, you're gonna kill them with that. No, you won't. An ICU nurse might in like 4 days, but not you. So don't withhold oxygen in that regard. But that's what a hypoxic drive means. It's the backup mechanism when your hypercapnic drive is too high. See, oxygen isn't the reason you breathe. It's the thing you take in to help you get rid of CO2. Truthfully, it's to kind of break down into water and all this kind of stuff. But I used to teach that oxygen was a poison that we need to keep us alive. And then I graduated a bunch of EMTs really afraid to give oxygen. Oopsie. Let's not do that. Now, I am going to skip a lot of this free radical stuff. If you can remember that we titrate our medications to effect, you're going to be okay. If you remember that there's largely 3 reasons we give people oxygen: because they said they needed it, because they look like they need it, and because they have a signs of dyspnea, complaints of dyspnea, or signs of hypoperfusion, then you're probably okay. But what we're starting to learn essentially is that too much oxygen in the unnecessary context is a problem. I don't have very difficult questions on free radicals. I really don't. But ordinarily, O2 splits up. It essentially binds with all kinds of other things to make various helpful molecules. In an ischemic or injury state, we'll get electron imbalance. Or in summary, I'm processing oxygen just fine. All of the electrons and molecules are balanced, no big deal. If I was suffering a heart attack or even a punch in the arm, that injury and inflammation is going to generate oxygen molecules that are unstable. It's part of the process, an unfortunate part of the process. Adding oxygen to that problem is not helping. So make sure you know that even though we are concerned about, we shouldn't give aspirin to people that aren't having chest pain, basically, right? Well, don't give oxygen to people that don't need it either. We used to think it was no big deal. Turns out it can be harmful in some ways. Now, even the AHA, if you read that book on BLS, will tell you the AHA is still not like super comfortable saying withhold oxygen. What they are saying is use it with caution. We put a metric out there. If you think it might be ACS, what's ACS? Acute coronary syndrome, what does that mean? Heart attack is one of them, sure. Atherosclerosis is essentially the other one. If they might have a coronary artery issue, we're going to let that SpO2 drop. So when to give oxygen? Complaints of dyspnea, signs of poor perfusion, right? Look, if you're on the fence about oxygen, give it as a clinician. If you're on the fence, give it. But you could probably get away with a nasal cannula if you're on the fence. If I walk in and this guy's like, hey, I'm having trouble breathing, I think I'm having a heart attack. I say, okay, well look, you feel like you're having trouble breathing because of the heart attack, not because of deoxygenation. He's like, no, I need oxygen or I'm gonna die. Okay, I'm gonna put that guy on a cannula and say, all right, we're gonna let this cannula do its work. It's much easier to defend than blasting him with 15 liters of a non-rebreather, which isn't helping him anyways, because his issue isn't lung problem, oxygen problem, it's blocked artery. Uh-oh. Mr. Simmons is going to send me some pictures. We better get rid of that. Oh, and I got my Discord open? Oh boy, you definitely don't need nothing from my buddy Stevie. Okay. SpO2 is not the whole story. You should not look at an SpO2 and say, oh, I know what this is. This is recommendations for what it might be. We'll need to be able to differentiate these concepts. Just like we're starting to differentiate airway from breathing, ventilation is not respiration. These are different processes. Ventilation is mechanical. This is the physical air moving into your lungs. Respiration is gas exchange, which means it's now going across cell walls. If ventilation is the mechanical movement of air, and respiration is gas exchange against the over a cell wall, what's happening in the trachea? Ventilation or respiration? Ventilation. What's happening in the mouth? Ventilation or respiration? In fact, where is respiration occurring in the airway? At the alveolar wall, right? And the alveoli. Now, perfusion is the blood delivery. If I'm ventilating fine, meaning I'm pulling in air into my lungs and it goes down into my alveoli, am I okay? Well, it's a good start. But the next question is okay, so ventilation is fine. How's your respiration? Is air now getting across the alveolar wall? Is O2 going into the blood? Is CO2 coming out of the blood? That's respiration. Because if it isn't, it doesn't matter how well you're ventilating if you're not respirating well. If I have 100% nitrogen in this room, are you having a problem? Yes, but you're ventilating just fine, but that's not the issue, is it? The issue is you're not getting oxygen, you're not having respiration occurring effectively, right? You need oxygen. So if air comes into the airway, that's ventilation, then air goes out of the alveoli into the vascular system, the capillaries, right? What needs to be there to help pick up the gas exchange? What needs to be in the vasculature surrounding the airway to pick up the gas? Say it again. Blood, essentially, hemoglobin. So now it's another thing. Oh, I'm ventilating. Am I just fine? Well, it depends on your respirations. Are you respirating fine? Is it going across the cellular wall? Okay, well, I'm respirating fine, but that's still not enough. How is his perfusion? Is the blood both getting to the lungs and then getting to the target organs? So there's a lot there, right? Guy might be breathing just fine, respirating just fine, but if he's got too little blood, he's got too little perfusion, he's still having a trouble, right? Even more than that is oxygenation. So the guy's ventilating fine, he's respirating fine, and his blood is getting there, but is the oxygen binding to his hemoglobin? So there's a lot involved in this process. If I told you, hey, if a guy's not breathing, breathe for him, then you're great. You're half the way there. If I say, hey, make sure that you know that just because a guy is breathing, he can still die of lack of oxygen. And if you're like, yeah, I know it has something to do with this, I'm like, okay, you're close now. Just moving air isn't enough. Rossi?
For oxygenation, like that's like when your pH is too high or something like that?
Oxygenation is literally the oxygen binding to your hemoglobin.
Yeah, but it can't do that if your pH is too high, right?
Or too low.
Yeah.
Well,
So what do you do in that?
woof, there's a lot to do. We'll talk about it at another time. First of all, to answer your question, Rossi, you won't know about a person's pH even if you suspect it, but this I see a lot in the medical field, and EMS specifically. Students will get so trapped on the physiology of something that they won't act. I'm like, you don't have an intervention card that talks about the pH of blood. You got one that talks about hypoxia and hypoventilation, do that. If you don't have an intervention on it, I don't expect you to be able to interact on it. In fact, even as a medic, outside of some very specific instances, I won't affect it either. Make sure you know this, that the majority of oxygen, make sure you know that atmospheric air is 21% oxygen. Make sure that you know that the vast majority of volume you take in is actually nitrogen. Make sure you know that our body only uses about 4% of that oxygen, which means when you give mouth to mouth, you're giving how much oxygen? How much? Well, you're giving 17, but yeah.
Wait, how much are you giving?
Well, if I breathe in 21 and use 4%, it's 21 minus 4, so about 17% oxygen. Meaning, the big point of this is, you might be like, why do I care? Why am I slicing it so thin? I just mean to say that air movement is usually still oxygenation. Even if I'm using it and then breathe it into your mouth hole, I'm still giving you oxygen. And part of that is just to curb people's instincts to be like, BVM, oxygen now. And I'm like, no, BVM, oxygen later, because you're getting oxygen now. Make sure you know that through inhalation and exhalation, we have different descriptions of what's happening. The diaphragm is a muscle that spreads across your waist like this, because above the waist, and it's like an umbrella. It contracts down like you putting the umbrella away. It contracts down. That creates a vacuum in your thoracic cavity. So in a certain sense, you're not like pulling air in. It's not an active, it is active. You're creating negative space in your chest, and then air is filling the vacuum. It's kind of a strange concept, but the point I'm trying to make is that you have to have energy. You have to have a working diaphragm to pull air in. The default nature is relaxation, right? Much like a relaxed arm just falls, a relaxed diaphragm isn't pulling in air either. So inspiration, inhalation is the active part of it. That's where energy is being burned, to pull the diaphragm down and allow air to come in. Your muscles contract, and it creates negative pressure. You got weird questions in there. Which part of, like, ventilation is positive pressure, whereas natural inhalation is negative pressure. It's creating a vacuum in your chest. The Herring-Brewer reflex is a stretch reflex. Essentially, it's saying, if you didn't have what we've labeled the Herring-Brewer reflex, you could breathe in until you exploded. You know full well that you can only breathe in so much and then stop. Why? Because your diaphragm suddenly can't contract? No, it could. It's this reflex, kind of a stretch receptor saying, oh, that's far enough. And then it will essentially disable your ability to do so. So the Herring-Brewer reflex essentially prevents overexpansion of the lungs. The best way through remembering which is which here is to remember that a BVM and CPAP are positive pressure ventilations, which must mean that natural ventilation is a negative experience. That's when our muscles relax. It's the passive part of the process. This essentially is an image of a little short I found this morning about a guy creating a diaphragm here with lungs in this chest cavity. And then he pulls down, he contracts the diaphragm down like an umbrella, like I said, and it fills the lungs because it's filling in. I thought it looked like a bikini. So, in any event, I had the video here, but there's some chick laughing in the background, maybe want to drill my eyeballs out. So there's some images of essentially what's happening in the thoracic cavity with the active pressure. Make sure you know these things. We're already halfway there. Phrenic nerves, essentially C3 through C5. Here's a new one for us, though. The thoracic nerves, T1 through T11. What this means is that even though I have a fracture at C7, it doesn't mean I'm free from breathing issues. Because your intercostals are innervated farther down, so you might still experience some difficulty breathing. I would rather have an intercostal issue than a diaphragm issue, that's for sure, but in any event, you can still have breathing disruption even if it's in the thoracic spine. There's a whole host of things to know about breathing rates and how it's broken down by age ranges. Suffice it to say, if you're sweating bullets on this stuff, I can help you through. Like if you're trying to decide between memorizing pediatric vital signs or even being in EMS anymore, right? How I went through most of my career is this. It's not perfect, so be careful with it, right? But essentially, the minimum respiratory rate for an adult is 12, right? 12 to 20. Essentially, I just always remembered this as, okay, if you're smaller than me, like a child, it's double my rate. It's around 20, 24 or so. That's a normal minimum. If you're much smaller than me, then I triple it. That means if you're a little tiny baby that can fit in my arms, I'm starting to think that your minimum respiratory rate is 30. It's not perfect, but it's what I did for most of my career because I didn't know the numbers. That means if I'm holding a baby in my arms and they're breathing at 12 times a minute, they're almost dead. How do I know that? Because it should be around 36. In fact, babies freshly born, sit, hike, boom, right out of the womb, they're breathing at like 60 times a minute, once every second, which means if I get a baby out and they're breathing at 30, that is incredibly low. If they're breathing at 12, we're probably seconds from death. Tidal volume is 500 milliliters. How much is tidal volume? When we get into A class, we'll learn how that's not always accurate, but 500 will work for now. When we get into A class, we're going to talk about ideal body weight and how essentially it's something like every inch over 50 inches equals 2.3 kilograms. And then you factor it not on people's weight, but their body weight. But for now, what's the average tidal volume of an adult? 500 milliliters. How much air fits in a BVM? Like 1,800, 2 liters, way more than you need to squeeze. I'm moving quick here because we're almost out of time here. Give me just a moment. Make sure you know that tidal volume is your casual breath. If I said, hey, breathe in deep right now, that is not tidal volume. That's a different term. Our tidal volume is just what we're casually breathing in or out right now. That's about 500 milliliters, okay? Make sure you know that minute volume, much like cardiac output, is not just your volume, it's also your rate. Dead Space, not just one of the best games ever made, and it certainly is one of my favorites. Dead space is the term we give to the parts of your airway that are not doing gas exchange. Your trachea is dead space. Nothing's going across the walls there. It's going through it. Is air in an alveoli considered dead space? No, because that's where it's starting to go across. Okay, this will probably be the last I'm going to eat 5 minutes of your lunch or so here. This is always very tough for students, differentiating internal, external, and cellular respiration. But I think we can get through it, okay? External, ignore the expiration part, that's not accurate. External respiration is gas exchanging out of the lungs and into the pulmonary capillaries. This is essentially, external respiration is where air goes into the blood. Well, from the lungs into the blood. External respiration means the external environment into the blood. Internal is no longer specifically involving us going from the lungs into the blood. It's from the blood to the tissues or from the tissues to the blood. Because remember, respiration is both oxygen in and CO2 out. So if I take in a ventilation, air goes down into my alveoli, it's not yet respiration. Respiration, would it be going from my alveoli into my blood? That's external respiration, the external environment into my body. Now, as it goes down to the tissues and has cellular metabolism and then comes back, well, it's got to do external respiration again, right? CO2 has to come out of my blood and go out of my lungs. You with me so far? Now, internal is the target, right? I ventilate, external respiration brings O2 into my blood. That blood with oxygen, hemoglobin bound with it, goes out to my liver. The liver uses it up, puts CO2 in the blood. The blood comes back and out through my lungs, external respiration again, in and out. The internal is what's happening at the target tissue, whether it be your muscles, your heart, or whatever. Cellular respiration is inconveniently labeled essentially respiration, but I prefer to simply call it cellular metabolism. As oxygen leaves my lungs and goes into my blood, is that internal, external, or cellular respiration? It's external because it's going from the external environment into the blood. Great. It's then oxygenated and it's transported through my blood to get to my target organ. The oxygen then leaves my blood, goes into the organ, external, internal, or cellular. It's internal. Once it goes inside the tissue, that oxygen then combines with sugar to make energy. That's cellular respiration. The oxygen is now making energy. Then its byproduct is CO2. The CO2 has to then leave that tissue and go back into the blood, external, internal, or cellular. It's internal because it's going into the blood from the tissue. CO2 is brought by my blood all the way back to my lungs to go out from the blood, out through my lungs and into the external environment, hence external respiration, but now in the inverse. My hope is through the homework assignment, this comes easier when you just write it down. It's up to you. Say it again? Yes. Yep. Not yet. A class we will. Last thing I want to talk about hypoxemia versus hypoperfusion. Essentially, you can see over here, this has got all the blood, but not the oxygen it needs in it, hence cyanosis. Over here, it might have the oxygen it needs, but not enough blood. I'm still having a problem here, right? Hypoperfusion essentially refers to the blood flow. Maybe I'm breathing just fine, but if I don't have enough blood, I'm still up a creek. I need to perfuse and I need to ventilate and respirate and oxygenate just fine. This is differentiating the facets of our perfusion. This talks about cellular. Oh, you do need to know this. Here's how I get through this. Metabolism works better with oxygen. We can create a ton of energy with oxygen. Now, we don't create none without it, but we can create a ton with it. So aerobic metabolism is aerobic metabolism. Anaerobic metabolism is anti-air metabolism. Which one creates more energy? Aerobic or anaerobic? Aerobic. We work better with air, with oxygen. So make sure you know, I don't care that you know about 40 ATP or the Krebs cycle or glycolysis right now. What I care about is you know that if a person isn't breathing, they don't make no energy, they make substantially less. That aerobic is much more effective. And anaerobic is not only less effective, but it starts generating a lot of things we don't need, like lactic acid. Lastly, we'll get into about what metabolic acidosis and respiratory alkalosis. We'll get into this at a later date, but know this. If a person falls down in cardiac arrest, they are not breathing, right? But their cells haven't stopped metabolizing, which means what is building up in their body? CO2 is building up. They may not be bringing in any O2 anymore, but their cells are going to stop later. So more CO2, more acid. Essentially, a person who is a corpse is both experiencing respiratory acidosis and metabolic acidosis.